It's my distinct pleasure and honor to introduce our next speaker, Dr. Ann Stowe, who is an associate professor with tenure in the Department of Neurology and Neuroscience at the University of Kentucky, and is a member of the Center for Advanced Translational Stroke Science, the CAS. Her overarching hypothesis is that the adaptive immune system, driven by an autoreactivity to CNS-derived antigens, plays a fundamental role in functional plasticity and subsequent motor and cognitive recovery within the injured brain. Although she uses preclinical studies to investigate the mechanism by which adaptive immune responses affect post-stroke plasticity, it's critical to concomitantly confirm and characterize these cells in humans. Her clinical studies focus on the role of neuroinflammatory responses during brain injury and repair, and have expanded beyond the field of ischemic stroke to include subjects with or at risk for dementia, as well as pediatric patients on ventilator and hemodynamic support who experience stroke. The combination of preclinical clinical studies reflects both her own training, which included a clinical postdoctoral fellowship, and her ongoing scientific philosophy that translational research will hasten the collective understanding of functional recovery during and following brain injury. Please welcome Dr. Ann Stowe.
Good morning. Everybody can hear me. Thank you, Dr. Wong, for the invitation to come here, and Maimonides for supporting this, as well as thank you, Belly, wherever he is, for prodding me to keep me on target for getting here. This is my first day in Brooklyn, so I love it so far. I first would start with all of my presentations for thanking the lab. Here's my current lab members, a lot of whom have contributed to the data that you will see, as well as funding, and my collaborators, which I will show right here. So with disclosures, these are my current fundings, but I'm going to be talking to you about biomarkers and how they relate to precision medicine, which is actually what Dr. Wong was talking about, looking at the individual patient, and if we can identify ways with which we can determine whether they will be at risk for edema or hemorrhagic transformation, or if we can identify who's at risk for cognitive decline following stroke, which is a stroke is a leading cause of dementia. So in order to do this, we actually have started with some of the patents, a small company, which is mostly just a website right now, but this is how it works. So ultimately, my goal is to hopefully convince you that you should do biobanking in your patient populations to actually look at biomarkers of injury and repair. And potentially, if you need to collaborate with scientists, we would be happy to talk to you at the end about this. But Cerelux includes actually Dr. Justin Frazier, who's a neurosurgeon who started the collection that I'll be talking about a little later, along with Keith Pennypacker. And we have Dr. Cheng, who is a bioinformatics, and so he helps us with machine learning algorithms, which is mostly the patents that we have, as well as myself, and then Dr. Paul, who is our CEO. So learning objectives today, it's kind of, I'm usually a walk around and point, but we'll include some inflammation background, as well as what is a biomarker. You use these every day in the clinic, and we really are looking at both how you use current biomarkers, such as neuroimaging, as well as how we will identify new biomarkers. We'll look at some of how this is working in Kentucky populations. So this is a rural population in the state I'm in, very different than what you are dealing with right now. But I'll go over some of my data, looking at neuroinflammation again after large vessel occlusions, and finally sum up with what you can do in Maimonides and in the local areas to improve biomarker identification. So as has already been addressed, there's a real dearth in actually successful post-stroke therapeutics. And this came out in 2006 when I was finishing my doctorate. And while I was doing my PhD, there was a lot of stroke-related research going on in industry, and pretty much after this came out, that all went away. And within a matter of years, most large pharmaceutical companies stopped doing stroke research because nothing had worked. And I think that part of that is because when we look at stroke, it is so individualized that it's difficult to find, other than TPA and a lot of the large acting therapeutics, it's difficult to identify what will actually work. So part of that problem, and related to what I will be showing you as far as my research goes, is the effect on on inflammation. And if you think of just inflammation, so how our brain is affected by our peripheral inflammation, you have comorbidities that affect your inflammatory response to stroke, including aging, diabetes, lifestyle factors that can be altered, sedentary lifestyle factors. Those all increase your chronic inflammatory status. Whereas if you're young, if you exercise, if you are on antibiotics or probiotics, those can inhibit a pro-inflammatory response. And what your systemic immune system is doing is individual in each of us sitting in this room, and it can all then affect how you respond to stroke, the neuronal injury, the infarct progression or regression, and mortality and functional recovery. So I'm trying to expand this so that you think about inflammation in your patient populations. Particularly because if we go into something like looking at biomarkers of inflammation, we have a long window of treatment. And here you have recovery of body functions and activity after stroke onset. You have initial deficits, but for your patient populations, you have weeks to months to actually do interventions. And a lot of what we have prior focused on is the acute time period, the first hours to days after stroke onset, but really understanding what can predict better functional recovery will improve overall patient quality of life. So as you have this long-term recovery, you can see that there's neuroinflammatory processes that cross over with neuroregenerative processes for weeks to months. And some of the early work from my doctorate actually looked at long-term functional plasticity. So I'm not going to go into this, but I want you to think about when you recover, it is not usually the area of infarct or the peri-infarct region that supports recovery. It's the rest of the brain. Everything that has survived a stroke actually will reorganize. And here in a non-human primate model, we showed that axons normally interconnected to the somatosensory cortex will reroute around in a mammalian brain, go at right angles and actually reconnect to novel areas. And this takes months to occur, but this is happening. And this is where I think biomarkers for long-term cognitive and motor recovery are going to really be beneficial in the next decades. Ultimately, then, my lab focuses on identifying some of the adaptive immune responses that occurs. So in this, I'm talking about your lymphocyte responses that are antigen specific. So these are what mediate vaccines, and this can also occur post-stroke and actually either impede or promote functional recovery depending on your lymphocyte subset. And going back to your stroke patients, if you have somebody with untreated rheumatoid arthritis, for instance, or somebody who's just had an infection like COVID, you are going to have a very different inflammatory response, and these cells will move into the brain. They will move into the brain in areas that are not necessarily right at the infarct, but undergoing plasticity to support recovery, and they can be detrimental, as I said, or beneficial. So in talking about this, how do we define a biomarker? And as I've mentioned for everybody in the room, probably but me, who are clinicians, this is including neuroimaging, psychological testing. You've seen this in both of the prior presentations. Your stroke scale, your CT scans, histology. This can also include fluid or tissue analysis for proteomics, genomic studies, and metabolomic studies. And this is, I think, really key. And a lot of what we need to do is using artificial intelligence and machine learning algorithms in massive data sets to actually identify relevant biomarkers. So as you are already working with biomarkers, which ones are actually relevant for patients? This is not going to be one glorious the biomarker, capital B, that will be beneficial for everybody, unfortunately. But when we think about a biomarker, it needs to be cost effective and quickly obtainable, ultimately, without or minimally invasive. So imaging is minimally invasive. Obviously, blood draws are a little more invasive, but it should be able to be acquired rapidly. This method should be able to be standardized. So if we're looking at a biomarker that is usable to understand who will be at risk for cognitive decline, you need to be able to have it standardized between hospitals. Collecting the biomarker data should be possible while maintaining human subject protection. So I don't think anybody needs an IRB to potentially take a blood pressure test or a temperature. So ultimately, our biomarkers that are going to be the most applicable, particularly for populations who are not in underserved communities, would be something that would be relatively easy to maintain without an IRB. And they should have a signal that's not heavily influenced by all of the co-founders that affect stroke outcomes. And this is going to be more difficult. And if you want my honest opinion on this, I think this is not achievable, but I think what we can ultimately do is find biomarkers, for instance, for women over the age of 65 with a high BMI. And you can look at them, look at those biomarkers, and then determine if they are at risk of cognitive decline. So unfortunately, I think the heterogeneity of both the disease and the population are going to make it difficult to find one set of biomarkers that's workable for everybody. But when we look at these biomarkers, we would like to be able to stratify patients who respond better to treatments. This, if you go back to everything that has failed in clinical trial, could be revolutionary. If you go back to compounds the FDA has approved and identify which patient subpopulations might actually respond to these compounds, you then might be able to show efficacy for something that has been, prior to this, disregarded. So I think that it's very important for clinical trials or to identify which treatments to apply to a specific patient. And in, for instance, rehabilitation aspects of recovery, if a patient might not have or have a BDNF polymorphism and they will not respond to either transcortical stimulation therapies or other peripheral therapies, maybe you need to extend rehabilitation longer based on the individual patient. So when we talk about precision medicine, this is some of what we are trying to achieve as a community. We'd like to monitor the response for information whether a treatment should be changed to improve efficacy. I think you all agree with this as well. And what we have challenges with actually at Kentucky is our stroke patients who are enrolled for thrombectomy. I'll show you that in a second. They actually do not have, it's difficult to follow them into the rehab hospital because it's a different hospital system, a different medical record. The IRBs don't follow. So this is some of what I think would be nice to try to, I say this like completely not understanding the Herculean effort that this would take, but this is what we would need to do to actually follow a stroke patient through. Finally, as I mentioned, to focus this therapeutic field toward individual patient outcomes. So we've talked a little bit about inflammation and biomarkers. I'm going to give some examples of how this is working in Kentucky. And for those of you who have never been to Kentucky, I don't know how many that is, we're right here, and we are in the heart of the stroke belt. So we have a very high death mortality rate. This is the death rates from 2014 to 2016. We are sitting here. And part of this is because here are our Kentucky hospitals. So here as our comprehensive stroke center, Lexington and Louisville are the only two areas in the state of Kentucky that can do mechanical thrombectomy. So this is very different than the patient populations that you are looking at here, but it is critical for us to understand how we can use biomarkers to help speed the process and improve recovery, particularly for what is a 200-mile radius watershed of hospitals that will send their patients to ours. So this is massive, hours in an ambulance that are sent to come to Lexington. And part of this is actually, the first part I'm going to talk about is something that's ongoing right now with our neuroimaging biomarkers for patients in Kentucky that have large vessel occlusions and are potential thrombectomy patients. And this has really revolutionized our treatment. And I don't think it's applicable here, though it did take a really long time to get to the hotel from the airport. So you might actually have some traffic issues that could be related to this also. But what we are using is Viz AI. Is that used here? Viz AI. Okay, so I have no stock in this company. This is just what we are using. But we're using an AI-powered platform for neuroimaging. So we have our spoke hospitals that will scan Viz AI, and I'm actually going to show exactly how this is affecting patient care at Lexington. Transfer then to the treatment hospitals. And so here in general are the scans that have come under the Viz AI from May 2021 to May 2022, so 1 year. The AI then detects large vessel occlusions automatically. 237 were detected, which is so different than the 5,000 that I just saw in a couple years' time here. But this is Kentucky and fewer people. What is great is that within 5 minutes, 99% of these scans were actually reviewed by the on-call physician at our university. And what this shows is a 45-minute improvement from door to revascularization time and 31-minute reduction in door-in, door-out times for the thrombectomy transfer. So this has been really foundationally fundamental to the treatment of stroke patients within Kentucky. And when you look at how this has, for thrombectomy, the ones that are transferred, the ones that stay at the local hospitals, so there actually have been a lot of patients who normally would have been transferred had they not been able to talk to a stroke neurologist that were able to stay, be stabilized, and remain at their local hospitals because they were ineligible for thrombectomy. And when we look at this here, you can see also that there's a 55-minute improvement in imaging to transfer time and a 77-minute improvement from door to decision times. So from an AI neuroimaging biomarker platform, this is precision medicine in the acute care setting that is able to look at each individual patient and tell us whether we need to transfer them to our hospital or remain at the individual hospital. So with this is something that is already ongoing, but I'm actually also going to talk about what's specific to us, and I'm happy to discuss this in collaboration with Maimonides researchers, but it's our blood and clot thrombectomy registry in collaboration. And we discussed a little bit about identifying some of the types of clots that are in our ELVO patients. But what this is a prospective trial. So everyone is enrolled in this prospectively. And this is actually collecting distal blood. So as the interventionalist goes through, they will pull a little bit back on the retriever to actually make sure they've passed and cleared the clot. That blood is usually discarded. So we now collect it for proteomics and genomics, as well as some flow cytometry, which I'll show you. And we also collect systemic blood, so carotid artery as a control, and sometimes venous blood as well. From this registry, we already have, as I mentioned, the 5 provisional patents and currently 13 publications. And we do have a few centers, including one in Hamburg, Germany, that are setting up the BACTRAC protocol to also join in this. So what is happening here and what are our goals? Because this is really, our goal is to improve stroke treatment with using precision medicine. We use the biological aspects of our blood draws, proteomics, transcriptomics. We've published on short chain fatty acids and blood gases as well. We then combine it with the clinical aspects. So our radiology, our NIH stroke scales. We currently have an NIH grant now to look at these patients at 3, 6, and 9 months later with an NIH stroke scale to determine cognitive decline potential in these patients. We use both standard statistics as well as machine learning to identify predictive markers, as well as potentially novel therapeutic targets. And then we are reverse translating this back to some of the animal models that we study. Dr. Pennypacker has a rat model of transient MCA occlusion, and I use mice. So what have we found so far? This is actually looking at some of the genomic data. Using our machine learning algorithm, you have a lot of inflammatory responses within the blood that can actually predict both infarct volume and edema. We've published some of this. So now we're getting down into identifying at time of mechanical thrombectomy what proteins are elevated within the blood collected systemically and intracranially that can predict potential subsequent injury. This would then be, if I were to have like the best case scenario, a small laminar flow device that would be in the interventionalist could use, take the blood out, put it on the laminar flow device, see, yes, they're going to be at risk for edema, no, they are not, and then be able to alter their trajectory of treatment based on the biomarker. And from what we have seen, this is almost summarizing a lot of what we're looking at, and I won't belabor the inflammatory responses, but we have a lot of cytokines, IL-9, IL-5. Some of these already have FDA-approved therapeutics that could be given as adjuvants to mechanical thrombectomy. So at the time of stent retrieval, if you wanted to put in, if they had a high IL-7 or IL-9 titers, you could put in an anti-inflammatory drug at the site of occlusion at the time of thrombectomy. So this is not, we're not there yet. This is just what our preliminary data shows. And as I mentioned, we're rather slow in recruiting patients, so collaborations are very welcome. But also we can use machine learning algorithms. This is one of our patents to look at using systemic blood to predict severe edema. So now we get into, originally, a lot of our early data was looking at the intracranial blood, but this is a thrombectomy center. So this is very few of the actual stroke patients in the state of Kentucky that will be able to go there and have their intracranial blood tested. So instead, we're trying to use systemic blood because this is far more applicable to areas that do not have comprehensive stroke centers that are in need of treating patients. We've also looked at hemorrhagic transformation, and we do find, I do not understand all of the machine learning statistics or algorithms here, so my apologies. If you need further clarification, I'm happy to put you in touch with Dr. Cheng, but we have IL-1 alpha. A lot of these chemokines, and MCP1 is CCL2, so a lot of these chemokines and cytokines are actually predictive of transformation to hemorrhage. This would be, I think, very beneficial to be able to identify from the systemic blood if you have a patient that might be at risk for this, particularly, again, if they're not at a comprehensive stroke center. And the last couple slides for this part of the talk I'm going to go through are going to focus on this set of genes right here. So this is taking our systemic blood from patients. We sent it to Olink, which is going to be a standardized analysis of protein expression in these patients. And then we divided them between Appalachia and non-Appalachia. And as a little bit of background, we are predominantly a very homogeneous group. White is about 90% of our population. So we do not get to have a lot of racial and ethnic diversity in our patient population, but what this does allow us to do is look at where they originate from. And so Appalachia has a lot of coal mining, a lot of environmental toxins, a massive underserved community, as you can see, for even primary care physicians. There are certain counties, I think there's 7 counties in Kentucky that do not even have a doctor, a primary care doctor within them. So Wrap your head around that. And now look at, these are age and comorbidity matched stroke patients, patients, stroke patients matched from either Appalachian coal-producing counties in the east or non-Appalachian. And what we find is, if you look at the intracranial response to stroke, it is identical almost between group patients. And so you have these genes are here on the X and Y axis. One would be a 100-fold increase, and a decrease is in red. So generally, your intracranial response is the same. But what's happening systemically is, for this area, a massive upregulation of genes that are associated with environmental toxins and an environmental toxin response. Whether these environmental responses are already in the patients or if this is upregulated with the stroke injury is unclear, because we have not gone out and actually done the studies. But what this highlights is that if you start using biomarkers to look at your patient populations, you might be very surprised at what you find based on potential occupation or occupational hazards, where they live, water quality, coal and air quality. There's a lot of radon in these areas too. So we now have an environmental toxin response in our stroke patients that may need to be addressed to help improve functional recovery. This is very, very difficult to actually deal with, though, because a lot of these patients live 2 to 4 hours away from our hospital. So rehabilitation is also a struggle in this population. So being able to determine what molecular responses are impeding recovery versus just what systemic responses are impeding recovery are something that we hope to focus on in the future. But as I said, we've got a lot of therapeutics that have failed, and we have a lot of the US that really needs to have interventions that are specific to their to stroke. And hopefully, as we move forward, that we're able to get more people involved in collecting biosamples. Either you do it here or you work with us, but we can start looking at individual patient responses and better understanding what is generalizable and what is very specific. So with that, I'll go through briefly a little bit of my specific contribution to the BACTRAC. So BACTRAC with Dr. Fraser and Dr. Pennypacker was established. And one of the main reasons that I moved from UT Southwestern in Dallas to the University of Kentucky in 2018, I was very excited to actually be involved in the clinical aspects of this research. I thought it was exciting, and from everything that I have learned about neuroinflammation and stroke, which is the focus of my lab, it's all been from animal models. So this paper came out, actually, Dr. Gelderblom is a collaborator with us on BACTRAC in 2009, and this is one of the foundational papers identifying what is occurring in the brain when systemic immune cells move into the brain. So this happens across an intact blood-brain barrier. You do not need blood-brain barrier disruption in the infarct or peri-infarct region to have inflammation. This can occur anywhere in the brain. And early on, you have innate cells like macrophages and neutrophils. And here is your cells per hemisphere and days after stroke. This is in mice. You have this massive movement of your innate, non-specific immune cell populations moving into the brain. And into a much smaller amount right here are your lymphocytes. So your T cells and your B cells move out into the brain as well. And as I mentioned, the lymphocyte population is long-term. This is what we study. But if you think about this, you have, your brain is disrupted. You have neurons, astrocytes, endothelial cells. They all die. They all get broken up. Bits and pieces of them go into the blood, circulates, and can actually then activate the adaptive immune system for autoreactivity. And CNS-directed autoreactivity is foundational to diseases like multiple sclerosis or NMDA receptor encephalitis. This all happens after stroke. Every one of your patients has this, and some people might have a very negative response to these antigens. Some might have what is a physiologic immune response where it gets suppressed. Those cells get removed, which is what happens all the time through selection. And then there is not a negative response. But no matter what, these cells are long-lived. So we don't even really understand how the initial immune response to stroke affects a second stroke or a third stroke. What does that mean in your patients if they've had 2 strokes within the last year prior to the one that they are presenting with? How different is their inflammatory response, and what FDA-approved drugs could we actually use to help minimize this negative response? So as this was basically what we were looking at in my lab, I was very excited to look at this systemic or this distal intracranial sample and see if I can identify some of the immune cell subsets that are in there, which was a bit of a challenge because usually the intracranial sample is less than 1 cc. So it is a very small volume that we had to adjust our methods for. But I'm going to show you some of the data that were published last year. So this is 16 ELVO subjects with matching intracranial and systemic blood samples. We compared them to healthy controls, 25 to 63 years old, as well as a group of patients undergoing MR angiography for cerebral vascular disease. And here you can see 9 were females. We had a lot of comorbidities in this cohort, and this is the NIH stroke scale. So generally, we use flow cytometry, and I will just, this is my one really, I love this method slide. What this does is we take cells from the blood, we put tagged fluorescent antibodies to the surface receptors and proteins that are on the surface of the cells. They go through one at a time through a flow cytometer, and lasers will then flash on them, and depending on whether they have an antibody tagged or not, you'll be able to know, is it a B cell, is it a T cell, is it an activated B cell? And this is how the data look. Actually, each one of these dots is an individual cell, and we gate them. And now we are again using machine learning algorithms to unbiasedly analyze our stroke patient data. Really, this is using both TISNE and UMAP. So these are, for anybody who has done any flow cytometry, this is sort of the next gen, because traditionally you could draw your gate around a flow group of cells, and now that all of that human bias is removed. So excellent. We have certain protocols if anybody is interested. But I'm just going to point out the pretty pictures. So here you have all of these patients and healthy controls, and then our cerebrovascular disease controls. All of the data is concatenated here. And as you can see, B cells, for instance, are color-coded as this population. Monocytes are right here. Our NK cells, natural killer cells, are right here. So we've got innate cells. Our CD4, our T helper cells, are right here. And you look at healthy controls. This is in general what the population looks like. So this is what's flowing in hopefully most of all of our blood right now as far as populations. Is a very different response in those with cerebrovascular disease. So this is trying to hone in on even before the stroke happens and you are at high risk based on cerebrovascular disease. What does your immune profile look like? And then down here, if you look at your intracranial, the intracranial blood very closely mimicked what the cerebrovascular disease control blood looked like. So that was kind of cool, meaning that it's sitting there. If this makes sense, right? It's static. The cells are responding to the loss of oxygen and glucose, but they are not moving, so they're not doing a lot, right? Like they're incapable because they don't even have the energy to create an inflammatory response. But in the systemic blood of these same patients, you have a massive upregulation of cells, some of which are actually looking more like healthy controls. And if we go through and quantify this, here in red, you have systemic blood, and in blue, you have the intracranial blood of the same patients. So you can see each one is joined by a line. In the dotted line behind is our healthy controls, and then here's our cerebrovascular disease control profile, which is a one-time snapshot. And what is just really you should know is that the myeloid cells, the granulocytes, and the macrophages are all declined in this population, which this is the first time really that anybody has ever shown what happens in the animals, right? So your early innate responses, which we saw here, are increased in the brain parenchyma. We see this in the stroke patients. So whatever is in your blood at the time of stroke onset has a high probability of moving out into the parenchyma within this intracranial section. So this is actually confirming the preclinical data that had been around for a while. And while we cannot obviously look at the parenchymal data, we can confirm in the blood clot if the cells are going. And so here you have the gate for the neutrophils along the side from our flow cytometry, as well as neutrophils that were quantified in the clot field. And you can see that the patients that had higher neutrophil representation in the intracranial blood had lower representation within the clot. The patients that did not have neutrophils, that had them moving out of the intracranial blood, had a lot of neutrophils in the clot. So we're kind of being able to see now individual patient responses and what's happening, because this is significant, that as you lose neutrophils in the blood, they are moving out into surrounding tissue. What also I think is exciting and not exciting, I should not be excited about this data, but is an additional panel that quantified endothelial cells. So some of the concerns we had with grant submissions was that pulling this intracranial blood would actually be detrimental to stroke patients, which is standard of care, at least in our hospital, to ensure that you've passed through the clot. But in order to confirm this, we looked at endothelial cells, which for this flow data are these two quadrants right here are CD31 endothelial cells, and then here you have CD45. So your immune cells are sitting right here in the systemic blood, and you really see nothing for the endothelial cells. However, we did have two patients out of this group that had high endothelial cell markers, which is right here. So they had a lot of CD31 endothelial cells in the blood that we pulled out from the intracranial portion. And this one in particular, which is this patient shown right here, this is a real population. This is not an artifact of flow cytometry. And so why did this patient actually have high endothelial cells in the intracranial blood? This was the only patient of these mechanical thrombectomy patients that actually converted and had a massive hemorrhagic transformation and died day 7. So this endothelial cell presentation might suggest that the actual cerebral vasculature is absolutely breaking down in this patient. They are not adhering to the cell wall. Their compartments are now degrading in this patient, is in the blood. You could, if we were to move forward and develop this, you could develop a diagnostic to test whether CD31 is in the intracranial blood, which would maybe put this patient at a high risk for hemorrhagic transformation. We also finally showed that some of the immune-based biomarkers can predict an edema. So here's intracranial CD4 T cells and edema volume for patients. And so as the CD4 T cells increase, you have an increase in edema volume. All of this is correlative, obviously. So, and we are currently diving down into understanding specific subsets, like are these pathological Th17 cells or other immune cell subsets. We did have a relationship with BMI as well as last known normal. But this is all just the start. And this was 16 patients because we were in a very small state with a very small population of stroke patients. So happy to, as I've said many times, discuss this. So if I'm going to summarize this, we can confirm endothelial cells are absent from the majority of the intracranial samples. It is a safe procedure predominantly, and if they are there, it is most likely secondary to a cerebrovascular pathology that puts them at risk of hemorrhage. We have decreases in the innate immune cell populations, which is exactly what the animal data would have predicted a decade and a half ago. We have some T cell representations that are increased and may reflect pathology. I showed the Clot data, and we're currently trying to identify specific adaptive immune cell subsets. So really, what is our path forward? From a research perspective, I hope that we can really begin to identify, and this is going to take a community effort for certain, to be able to collect biomarkers. And in this case, I'm not just talking blood. Urine is a very simple biomarker that has a lot of pro-inflammatory responses that you can measure in it. You obviously have your neuroimaging and other physiological parameters, our behavioral assays, but we need to divide this by phase and stroke subset, which I'll show in a second, because really not only can you improve diagnostic precision if you can begin to identify biomarkers relevant to an individual patient and predict clinical outcomes or those at risk of negative outcomes, but it can also assist in patient selection for randomized controlled trials. I think that we are all agree we're tired of controlled trials in stroke that have failed. And if you can identify the subset that will be the best responsive group to your neurotherapeutic or your intervention, we need to be doing that a priori before we have any more loss of, loss of money and everything else. Oh, there's no, sorry. And then as I didn't really go through, but it can also be a great way to discover novel therapeutics. That's really kind of outside of my wheelhouse, but we have been working with some pharmacology individuals also to identify targets and novel targets for drug design and development, as well as monitoring disease progression and determining efficacy of the treatment you are giving. And so what is really required, and to think about this, is obviously we have different types of stroke patients: ischemic, subarachnoid hemorrhage, intracerebral, and there are different profiles for this. So we are right now looking at early brain injury following ischemic. We actually will be bringing patients back now at 3 months and 6 months, as I mentioned, and 9 months to look at cognitive decline. But this is a large effort and very different profile, actually, from, for instance, somebody with subarachnoid hemorrhage who will be hospitalized for a much longer period of time, potentially, and have both a risk of vasospasm as well as delayed cerebral ischemia. Identifying biomarkers for those would be excellent, right? So you could actually begin treatment early. Pediatric, I didn't go through, but that is far more difficult. I have done some work in pediatric stroke with children who are on ECMO and neonates, and we do see IL-6. There are a number of cytokines that can predict both loss of autoregulation, cerebral autoregulation, as well as put them at risk for acquired brain injury or having a stroke while on ECMO. And generally with ECMO, I think pediatric and neonatal populations, they do not do a lot of standard of care brain imaging following. And you are, for some of the patient populations, I mean, we've worked with 2-day-olds, so obviously you're not going to be able to do functional testing to see if they have had a stroke or not, but certainly you would adjust lifestyle treatments and interventions during development if you were able to identify that. So with that, lessons that we have learned, you need a dedicated staff. So if you are interested in this, it's going to the interventional suite, which I have done on many of an occasion. That's a couple of hours, right? That you're waiting there potentially while the patient gets stabilized and the thrombectomy procedure occurs before you can have the acquired biofluids if you're doing blood. And for the flow cytometry data that we do, this is about 6 to 8 hours post receiving the samples for processing. So this is a labor of love in the Stowe Lab. I don't know if the grad students love it, but I do. So, but this, you need a dedicated staff, particularly too with consent. So we had issues for consenting where we would, because this is a prospective enrolled trial, we would process the blood samples and not be able to get to the family or the patient within the 24-hour period and consent them, and then have to throw everything. Obviously, you have to destroy it all if you do not get proper consent. So time windows are key. If you are planning on doing this, give yourself more time to visit. This is particularly for us important because a lot of the families for the people who are here, they live hours and hours away. So this was just not as optimally designed early on, and we have hopefully remedied that. Also in the IRB consent, our original one did not have a request for follow-up, which again, as I mentioned, because our EMR systems and our hospital systems are different from the rehab hospital through the acute care hospital, this created a challenge. But now we have a portion of our consent that will allow us to be able to talk to these patients again. And of course, you need to be consistent with sample collection, processing, and storage. So if you want to be able to look at a patient population that you are collecting over a year or a 2-year period of time, you have to make sure that you are not degrading your samples over that period. So with that, thank you, and questions.
Anybody has questions? Eric, the constant.
Hi, Gary Friedman, Brookdale Hospital. It's a question for you and probably Dr. Wong in addition. I was impressed by the neutrophils, and you said IL-9 is pro-inflammatory. Going back to Dr. Wong's lecture, would this be an indication to use the neutrophil extracellular trap for treatment?
Ooh, that is an excellent question. Did I disclose that I'm not a clinician? But yes, what would you say with that?
Yeah, I think all these markers are important. I think we need to better understanding their contribution, how we can modulate them. Of course, those are the potential targets for the net, and as part of the treatment to disrupt the integrity of the clot, potentially to enhance your capability to lyse these cells, right? So certainly those are the biomarkers.
So the net would actually adhere to the neutrophils within the intracranial blood?
Actually, as part of the clot.
Oh, as part of the clot.
Right. So in the clot composition in there.
So a little, yes. So I see your point. So yes, then that would be beneficial for those who have the neutrophils moving into the clot. Identifying the net would be administered prior to thrombectomy, or?
Well, so the net is part of the thrombus, right?
Yes.
Right. So something that if you can identify that can target these things to destabilize either systemically for like TPA or locally with intra-arterial infusion of the medication.
Yes, definitely during post-thrombectomy, if you were to look at that biomarker at the time and see that there are no neutrophils in that intracranial blood, would also be a way to do that. Ultimately, a lot of these interventions, though, if you could get a systemic biomarker that predicts what's happening or what would happen intracranially, you could then treat even earlier than that. You're welcome. Thank you.
Yes, hi, Dave Ledoux. I have a quick question. I know looking for the magical biomarker, from the initiation of the cascade of, inflammation to cytokine and chemokine and integrins, negrins, all of those factors, doing work in subarachnoid hemorrhage and such, and looking at HMGB1 and MIF. It's very difficult to find what is the initiation of the cascade. So I'm just wondering that in rheumatologic disease, specifically rheumatoid arthritis or even sepsis, what they've looked at is cholinergic initiation to a lot of this cascade. And rather than like shooting a duck, a bunch of geese and trying to hit the right one, hitting the initial cascade, looking at the particular, maybe acetylcholine, vagal nerve versus trigeminal nerve stimulation, which may be associated with this cascade. Is that another alternative in looking at this?
Yes, that's actually difficult to model in animals. We tried to do some sympathetic studies. You have this fine line between wanting to be anti-inflammatory and not wanting to induce post-stroke immunodepression. And so, or immunosuppression. So if you're trying to target, I guess I would say I would almost shoot the ducks. And I know a few ducks would get away, but it might be better than just, I don't know, killing the flock on the ground. This metaphor totally falls apart.
It's frustrating because, I mean, what you found, which was fascinating, was the systemic to the CNS migration of particular cells. I mean, that's fascinating. But then again, then where do you go from there, looking at the majority of whatever receptor or, that you're looking for that you can one day block?
Right. I honestly think that even my focus on inflammatory in the acute hours after is not beneficial. I think there is so many confounders with a patient that we cannot predict a microbiome. I have a whole lecture on microbiome and how that affects inflammation in the brain after stroke. So these are all massive issues. And yes, being anti-inflammatory but not inducing immunosuppression, which actually then puts you at risk for pneumonia and other post-stroke infections, which then impedes recovery. I mean, it is a nightmare. It is a nightmare to try to understand. But if we don't start trying to understand and collecting samples, if you collect daily blood samples, that would be great, and start to look at how that then affects response to rehabilitation, particularly, for like matched cortical, stroke areas, stroke etiology matched, who responds to rehab, who doesn't. That's something that's difficult to initiate in our university, but would help go through that, because it's just a matter of, with AI and machine learning, we could collect biomarkers from 20 different hospitals, 10,000 different patients, and maybe actually be able to suss out from the noise what is a relevant biomarker for rehab. I think really, like I said, the days to weeks after are probably going to be a better chance for identifying something that can be targeted.
Appreciate your great work. Thank you.
Okay, you're welcome. Thank you. Are we good?
Any other questions? I think it's an amazing talk and very fascinating. Make us look forward what's going to be in the future. So it's very exciting that these things are done during the acute phase, analyzing what is reactive and in the blood. And have you analyzed the clot itself as well, besides the blood surrounding pre and post the thrombus?
We have not. We collect the clot, and there are a lot of other individual groups that are researching the clot and the clot formation. Like I said, inflammation is more what we do historically as we are trained. And so that's been our focus, more of the blood-based inflammatory markers. We have all these clots though. And we did section some of them, obviously, to look at the neutrophils, but no, we're not doing the clot.
I think that'd be, I think it will be interesting, not a different arena to look at this, because those are our targets in a way. So what we're trying to remove the clot or lyse the clot, that's one way to do that. Of course, that's the inflammatory response is all important, which may determine the response after the reconciliation.
Yes, yes.
I wonder, in that patient who had hemorrhagic conversion, you found there's, biomarkers for the endothelial markers. Do you think those findings are the results of the disruption blood-brain barrier, or is the kind of the underlying reason something else?
No, I think it's an underlying. So that patient did not have endothelial cells in the systemic blood. They only had endothelial cells in the intracranial blood. I think that is secondary to the loss of oxygen, and potentially like the ROS generation whatever it is secondary to, I think that is unique in that person and is some biomarker for a pathology of the vasculature that would put it at risk, or put that person obviously at risk for transformation. So
We do see these kind of cases, even though you have successful canalization, everything, they still go on to infarct and hemorrhage, and you lose the case. So it'll be interesting to identify if any genetic predisposition, besides the environmental, factors or acute, interactions.
yes, we have not, we have like ApoE and we've done some BDNF polymorphisms. We have not done a GWAS or anything. I mean, that all requires a lot of funding and
Resources.
support.
Yeah, I think that'll be interesting if you can.
I think that'd be very beneficial for the Appalachian stroke patients versus the non-Appalachian. Not that I don't know if you could go with GWAS from a transgenerational epigenetic focus. I mean, because a lot of these patients have been living there for generations in conditions that are probably, have a lot of environmental toxins. So
Or we can compare a Brooklyn patient population to Kentucky population.
that would be great. So,
Any other questions? Thank you so much,
okay,
Dr.
thank you.
Stowe.